International law usually moves through a sequence of treaties and legislative votes, but occasionally the machinery of diplomacy is replaced by administrative command. When that happens, traditional local legislation can be rapidly overwhelmed by international bureaucracy. On June 1, 2024, the World Health Organization adopted a comprehensive set of amendments to the International Health Regulations. In July 2025, citing concerns over national sovereignty, the United States officially rejected them. This map shows the direct result of that diplomatic schism. Nations are now divided into two distinct groups, those operating under the older 2005 framework and those bound by the newly enforced 2024 amendments. The amended text establishes a protocol for global administrative command, moving the WHO's mandate from technical advice to operational direction. These new rules prioritize resource redistribution and centralized efficiency, creating a framework where the management of global emergencies no longer requires traditional state-level legislative approval. The official defense from the World Health Organization is that these amendments simply modernize disease surveillance and promote fairness among member states. The new legal architecture was adopted right here, among delegates at the 77th World Health Assembly. The package was approved by consensus, a mechanism that relies on the absence of stated objections, rather than a formal recorded vote. To understand how these changes function in practice, we must look past the summary statements and examine the treaty text across three axes: emergency triggers, domestic implementation, and legal principles. Examining the specific legal mechanisms in the text reveals a structure designed to move international directives directly into domestic policy. Under the 2005 rules, the highest level of global health alert was a public health emergency of international concern, or PHEIC. It was based primarily on clinical and epidemiological data. This pyramid shows the new hierarchy: local alerts, PHEIC, and the new pandemic emergency apex. Expanding this reveals the criteria. It's triggered by the risk of substantial social and/or economic disruption, shifting the threshold from disease spread to political forecasting. Once triggered, this declaration imposes operational obligations. Member states are required to coordinate with the WHO to redirect their national health products into global allocation networks. Domestically, this declaration provides the legal authorization for national health agencies to initiate emergency resource redistribution protocols based on international forecasting. The Director General's unilateral decision acts as the mechanism triggering these domestic mandates, displacing local legislative discretion without requiring prior approval from a national parliament. The 2024 amendments also mandate structural changes inside every member state, primarily through the requirements of Article 4. This table compares domestic implementation. Column A shows the 2005 National IHR Focal Point, a communication center within a health ministry. Column B outlines the 2024 National IHR Authority, which must have sufficient seniority and authority to override other government departments during a crisis. Administrative law experts hypothesize that this structure functions as a technocratic shadow cabinet for health policy. This flowchart shows the path of command. When an international directive originates at the WHO Secretariat, it travels directly to the National IHR Authority, bypassing the traditional national parliament node. Because the authority is established to ensure compliance with a binding international treaty, its primary legal mandate is to implement global standards, even if those standards conflict with local legislative priorities. By embedding this specific entity into national governments, the framework institutionalizes global governments locally, operating with autonomy from traditional democratic checks and balances. These bureaucratic structures are guided by a revision to the treaty's legal principles, specifically within Article 3.1. This layout compares the core principles. The 2005 text respected fundamental freedoms. The 2024 text adds the mandate to promote equity and solidarity. In international law, equity and solidarity are mechanisms used to justify collective security and the mandatory sharing of resources among states. Elevating these terms to the same legal footing as human rights allows authorities to frame restrictive measures, such as lockdowns, as necessary requirements for global collective security. This legal shift directly supports the digitalization of global health documentation, described in Annex 6. This traditional paper vaccination certificate has been legally and technically formalized to include digital formats and international interoperability. This creates a federated model of digital health trust networks, where the WHO acts as the central directory for verifying medical records across borders. Article 3 provides the legal justification for using this permanent digital infrastructure to monitor and manage human movement based on medical criteria. To address criticism, the WHO points to Article 3.4, stating that nations retain their sovereign right to legislate and that recommendations remain non-binding. This table contrasts the official narrative with the forensic analysis. Article 3.4 recognizes sovereignty theoretically, but the Implementation Committee creates mandatory compliance triggers. Discretion is restricted by mandates to implement recommendations immediately. It's like holding a steering wheel while a GPS overrides the route. This expansion of administrative power and its resistance to democratic oversight triggered a geopolitical backlash in July 2025. Secretary of State Marco Rubio and Secretary of Health and Human Services Robert F. Kennedy Jr. issued a statement rejecting the amendments, citing concerns that they would allow the WHO to mandate lockdowns and travel restrictions. The U.S. administration argued that the centralized WHO bureaucracy is beyond repair, moving instead toward a bilateral model for global health security. In September 2025, international health law fractured. A jurisdictional gap now exists between nations following the new administrative command structure and those retaining their local health autonomy. These amendments shift the focus of international health regulations from medical science to the centralizing power of international